McGraw-Hill Ascent Audio presents Care After COVID, What the Pandemic Revealed is Broken in Healthcare and How to Reinvent It, by Shantanu Nundy, MD, narrated by Shawn K. Jain. Introduction. In March 2020, just as the first cases of the new coronavirus, COVID-19, were spreading across the United States, and before millions of Americans began sheltering in place, I flew to San Francisco to meet with a promising startup company. In my role as Chief Medical Officer of Accolade, I was exploring new ways to bring telemedicine, patients seeing a doctor by phone or online, to millions of working Americans and families. As the meeting wrapped up, the company's Chief Medical Officer, James Wantook, and I started talking shop about COVID-19. The United States had only a few hundred cases at the time, but it was already clear to us that a major pandemic was coming, and that testing would be the linchpin of our national response. James was worried about how his patients without access to a brick-and-mortar clinic would get tested. In passing, he mentioned a laboratory in Washington state that was considering mailing test kits to patients so they could test themselves for the virus at home. When I left the meeting, my mind was racing. At-home testing made sense. Although the coronavirus test requires advanced laboratory equipment to run, administering the test is very simple. I remember doing my first swab for the flu as a medical student. I took a sterile cotton swab out of a plastic kit and gently pushed it into the patient's nostril until it wouldn't go any farther. I assumed I had done it wrong, but the nurse observing me assured me that I hadn't. If it was that easy to learn, patients could test themselves for COVID-19. But then an even bigger idea occurred to me, one that could be a game changer for my own patients back in Washington, D.C., who were largely uninsured and often struggled with accessing care of any kind. If patients could test themselves at home, the entire care model for most patients with COVID-19 could be provided in the home, from triage to diagnosis to management, and finally to recovery. For an infection that was expected to affect as many as 100 million Americans and present mildly in 80% of them, that meant up to 80 million fewer people showing up to hospitals and clinics for testing and care, and in the process exposing themselves, other patients, and healthcare workers to infection. It also meant more equitable access for individuals who too often are left out of the system, individuals who don't have a doctor, are uninsured or underinsured, live in poverty, reside in rural communities, and are racial and ethnic minorities. As I headed back to the airport in an Uber, I found a crumpled boarding pass in my backpack and scribbled down how the process would work. Step 1. A patient with symptoms or concerns of COVID-19 completes a self-assessment online. Step 2. A doctor reviews the self-assessment and, if appropriate, mails the patient a test kit. Step 3. The patient swabs themselves and ships the kit to a lab for processing, with results available electronically in 1 to 2 days. Together with Kavita Patel, a physician at the Brookings Institution, I wrote a paper in the Journal of the American Medical Association in which we proposed at-home testing as an alternative to in-clinic and drive-through testing. While drive-through testing was a critically important innovation, its major limitation was scale. Ramping up drive-through tests made the most sense in densely populated areas, where hundreds of people can be served daily. However, we also needed to consider rural communities, where 1 in 5 Americans reside, as well as people in nearly 10% of households without a car. Drive-through testing still placed demands on healthcare professionals to administer the test and required investments to set up testing sites. In comparison, at-home testing could leverage the national postal system and private mail carriers and be run without staff. I followed up with opinion pieces in the Washington Post and Harvard Business Review, and spoke with anyone who would listen, from policy experts to news reporters to healthcare executives, about the need to scale up home-based testing immediately. The response from doctors, patients, and business leaders was overwhelmingly positive. Their primary question was, when will it be available? But the powers that be balked at the idea. Some were worried that the model would lead to over-testing. Others were concerned that patients wouldn't administer the test properly. Still others feared that care would somehow become less personalized or lower quality. Despite my assurances that test requests would be evaluated by a physician, that patients could be coached over video on how to administer the test, and that the model would strengthen, not replace, traditional medical care, the idea didn't take. Just a few weeks later, the U.S. Food and Drug Administration, FDA, announced that at-home testing was not authorized. I was massively frustrated. Although lack of test kits was still a major bottleneck, here was a pragmatic solution that could more efficiently and equitably distribute the test kits we had. Over the next several weeks, more research was done that proved that at-home testing for COVID-19 was efficacious and led the FDA to reverse its decision. In June 2020, a major national laboratory company, LabCorp, began offering home-based testing. Soon, other testing companies followed suit. But it was too little too late. Lack of testing had become a national embarrassment, and the U.S. epidemic was already well out of control. This is a book about the future of healthcare, a future that COVID-19 has shown us we can't afford to keep getting wrong, and that, in many ways, has already ushered in. My aim here is to prepare you for the transformation now underway. Healthcare has changed more in the past several months than perhaps at any similar period of time in its modern history. Almost overnight, care has become more virtual, more home-based, and more patient-directed. These changes have profound implications for every stakeholder in the system. Understanding what this means for you and your organization is essential to succeeding in the post-pandemic world. But at the same time, we've come up short. As we learned in the opening example of at-home testing, we could have done much more to effectively respond to COVID-19. There is also more we can do going forward to address not only future pandemics, but also mental health, diabetes, obesity, and the conditions that routinely impact our health. What we need now are fresh ideas and new thinking about how to tackle age-old challenges in our delivery system, including access, affordability, and equity. COVID-19 isn't just a once-in-a-century pandemic. It's a once-in-a-century opportunity to reinvent healthcare. The future of healthcare, I argue here, is distributed, digitally enabled, and decentralized. To help you navigate the path forward, this book is structured around these three shifts. Each chapter starts with a vision of where healthcare needs to go, outlines what it will take to realize the vision, and offers a set of specific actions each major stakeholder in the system, including patients, can take to get there faster. But first, what do I mean by distributed, digitally enabled, and decentralized? Distributed. Care will shift from where doctors are to where patients are, at home and in the community, chapters 2 and 3. Healthcare will routinely be delivered virtually by phone and video, not only for urgent visits, but also for primary care, chronic care, and mental health. In addition, doctor visits and even hospital-level care will increasingly take place at home. Digitally enabled. Healthcare and the relationships central to care will be strengthened by data and technology, chapters 4 through 8. Care will shift from siloed to connected, from episodic to continuous, from being between one doctor and one patient to more collaborative. It will move from one-size-fits-all to personalized. It will go from relying on the doctor's memory to being powered by data. Decentralized. Decisions about care will more often be in the hands of those closest to care, chapters 9 and 10. The power to determine who gets care and how they get it will shift away from governments and insurance companies to communities, employers, doctors, and ultimately to patients and their families. Together, these shifts present a framework to understand the new healthcare landscape and make strategic decisions that will impact you and your organization. During the pandemic, care became more distributed as many patients, for the first time, saw the doctor over the phone or video. It became more digitally enabled as many doctors began using text messaging and mobile messaging to communicate with patients between visits. It became more decentralized as the government ushered in a series of new regulations that made it easier for clinics to decide where and how to deliver care, including online, in the clinic parking lot, and at home. But many of these changes were reactive. Had we more deliberately aligned our strategy with this framework, the outcome of this pandemic might have been much different. This framework will be even more important in the post-pandemic world. What COVID-19 has brought into sharp focus is that our healthcare system is fundamentally flawed. This makes it not only maladapted to responding to pandemics, but also to delivering routine preventive and chronic care. We don't provide care to patients where and when they need it. We don't leverage data and technology to strengthen healthcare relationships. We don't let frontline health workers decide how best to deliver care. The result is a system that is unaffordable, ineffective, and inequitable. At the same time, the pandemic has been accompanied by a set of deeper cultural shifts that will continue to drive changes in the health system. Patients began to see clinics and hospitals differently, as places that may not always be safe. Doctors realized that much of patient care can be provided virtually and outside of a healthcare facility. Policymakers couldn't help but acknowledge that healthcare is deeply inequitable. Employers began to consider healthcare as essential to business continuity. Insurance companies realized that the traditional model of fee-for-service payment made healthcare less resilient. Regardless of whether individual policies enacted to respond to COVID-19 are reversed after the pandemic, these cultural shifts will likely remain and impact the healthcare system for decades to come. The upshot is that the rules that have long entrenched the health system have been rewritten, and perhaps surprisingly, largely in a good way for patients. To take best advantage of it, all of us, patients, caregivers, doctors, healthcare professionals, health systems, employers, entrepreneurs, investors, and policymakers need to understand this new landscape and change our behaviors and strategies accordingly. I've spent the past 20 years straddling the old healthcare world and the more digital one we've been ushered into. As an undergraduate, I studied engineering at MIT. I went to Johns Hopkins for medical school and then got an MBA from the University of Chicago. I've worked at a series of startup companies in digital health, artificial intelligence, and population health, conducted research with and held positions at the World Health Organization, Centers for Disease Control and Prevention, and the World Bank Group, and taken care of patients in East Baltimore, the South Side of Chicago, and Washington, D.C. Today, I continue to do the same. Monday through Thursday, I'm Chief Medical Officer of Accolade, a health technology company that helps millions of Americans get the most from the health benefits their employers provide. Each of our members receives access to a health assistant and a team of clinicians over the phone or using a mobile app who use data and software to help them navigate the healthcare system. Fridays, I practice primary care at a traditional brick-and-mortar clinic that provides care to the underserved on the outskirts of Washington, D.C. As I write this, the pandemic is far from over. 8 billion people have just had their lives disrupted by a healthcare crisis. Millions have died. The prospect of reaching the other side only to find a healthcare system that is still too inaccessible, too wasteful, and too inequitable is almost unbearable to consider. But there is reason for hope. This crisis has created a wedge for change. The pandemic has tapped the vein of heroism and ingenuity that drew me and so many of my colleagues to our calling. Out of this pandemic, a new model for healthcare is emerging, one that is built around patients, enabled by technology, and driven by healthcare workers. We each have a role to play in the work ahead and a stake in getting it right. Let's get started. Chapter 1. COVID-19 as a Catalyst. On Tuesday, September 11, 2001, the world changed. The Twin Towers came down. The Pentagon was hit. First responders dug through the rubble searching for survivors. Universities and schools closed. The mood of the country and the world darkened. Daily life changed afterward. Flying would never again be the same. We learned to take our shoes off going through security and not to expect warm hugs at the gate. We routinely open our bags for guards at museums, sports events, and concerts. Americans also changed. We were forced to acknowledge that safety is a relative term. We are all vulnerable, and that we are in this together. On Wednesday, January 22, 2020, the world changed again. The United States confirmed the first case of the novel coronavirus on U.S. soil. Within 2 months, coronavirus, officially SARS-CoV-2, spread across the country. Universities, schools, and businesses closed. Millions of Americans started working from home. Hospitals and intensive care units, ICUs, in major hotspots like Seattle and New York City, overflowed with patients. Test kits and surgical masks to protect healthcare workers were on backorder. Toilet paper ran out. Although the pandemic is not yet over, it's already clear that healthcare will not go back to the old normal. But the question is, what should the new normal look like? This question is essential if we hope to mitigate the next pandemic and improve the day-to-day experience of care. To answer it, we need to start by understanding what made COVID-19 unique and why our healthcare system was so poorly prepared to respond to it. What made COVID-19 unique? As the first cases of COVID-19 reached the United States, I needed to understand what was going on and what to expect. As Chief Medical Officer of Accolade, I had to develop a strategy for our 1,200 employees spread across 4 geographic areas: Philadelphia, Seattle, Scottsdale, and Prague. I also needed a strategy for our customers, large and small employers, including healthcare systems, major airlines, and retailers, for whom we provided healthcare navigation services. I also needed to get up to speed to take care of my own patients and to respond to my family and friends, who were already starting to call and text, asking whether they should seek medical care for flu-like symptoms, travel for work, or cancel their summer vacations. The first weekend in February, I hunkered down in my basement office for a crash course in COVID-19. In the 15 years since I had started my medical training, the world had dealt with several major epidemics: H1N1, Ebola, and SARS. I needed to understand what made COVID-19 so different from other viruses, and what that meant for how our health system needed to respond. I read every research study and report on the virus I could get my hands on. I emailed colleagues whom I had worked with at the World Health Organization, the Centers for Disease Control and Prevention, CDC, and the World Bank. Over the course of the weekend, I came to realize why COVID-19 would pose a unique challenge to healthcare systems globally. The extent of asymptomatic spread. Individuals without any signs or symptoms of COVID-19 can carry the virus for days and still transmit it to others, and even remain asymptomatic for the entire course of their infection. This meant that we couldn't simply rely on people's symptoms to know when to isolate them to break the chain of transmission. Moreover, for those who became symptomatic, the symptoms were largely indistinguishable from other flu-like illnesses, making it nearly impossible to know from symptoms alone if someone had COVID-19. Testing would be essential to diagnosing COVID-19 and tracking the spread of infection. It dawned on me that our ability to scale up testing to reach everyone who needed it would determine the success or failure of our response. Knowing that access to healthcare was already a problem for far too many people, I could see that we had our work cut out for us. The extent of severe cases. Although estimates varied, early reports suggested that 20% of those infected developed severe respiratory systems requiring hospitalization, and 1 to 2% of patients died. These rates were even higher in older adults and individuals with chronic conditions such as type 2 diabetes. The high rate of severe cases meant that hospitals, which typically operate at or near capacity worldwide, would quickly become overwhelmed. Worse, as places that already are known as breeding grounds for infection, hospitals would also become sources of spread among patients and healthcare workers. It also meant that individuals with poorly controlled chronic diseases, the elderly, the poor, and the disenfranchised, would suffer disproportionately. Because healthcare systems are weakest in disadvantaged communities, reaching those areas, which our health system has never managed to do well, would be essential to our response. At the same time, because younger and healthier people were less likely to be severely affected, they might be less likely to practice prevention than they were during the Ebola epidemic, which had high rates of mortality across the age spectrum. This meant that a strong public health response to prevent the spread of infection in younger people would be imperative. And yet, this too is often where our system fails. widespread disruption to routine care. The need to slow the spread of infection, as well as the heightened, and often well-founded, fears of getting infected in a hospital or clinic, would cause many people to stop or delay seeking medical care. This would mean widespread disruptions to preventive and chronic care. At the same time, the need for these services would be greater than ever. Chronic conditions would be exacerbated by the social determinants of health. As businesses closed or slowed down, joblessness and financial insecurity increased, and food security became more of an issue. And mental health would worsen due to widespread fears and social isolation. We already had data from the 2014 to 2016 Ebola epidemic suggesting that such widespread disruptions to routine care could lead to as many deaths as the pandemic itself. I realized that we would be dealing with two pandemics at once. First, the infection itself, and second, the increase in chronic disease and mental health issues, what I later defined in a paper with my colleagues Manmeet Kaur and Prabjot Singh as the second hit of COVID-19. The dual pandemics would require the health system to be responsive and agile enough to shift care to where it was most needed. Unfortunately, responsive and agile are probably the last two words most people would use to describe the healthcare system. In short, COVID-19 was the perfect storm, a virus almost perfectly engineered against not only the human body, but also the way we humans had designed our healthcare systems. It was an infection that spread as fast as H1N1, caused as much death as SARS, and disrupted society as much as Ebola. If we had any hope of containing this pandemic, we needed a new health system, and fast. 2 steps forward. Elements of that new health system came sooner than I could have possibly imagined. A few weeks into the start of the U.S. pandemic, on a crisp, sunny March morning, I drove into my clinic in Washington, D.C. Aside from the empty roads, it seemed like a normal day. But when I got inside, instead of being greeted with a busy waiting room, I was handed a clinic smartphone. Almost overnight, our clinic had put in place a new protocol. Every patient had to be seen virtually first. Afterward, if the patient appeared to be free of COVID-19 and needed to be seen in person, they could be scheduled for a face-to-face visit. In the 10 years I had been practicing medicine, I had never done a patient visit over the phone or by video. I wasn't sure exactly how it'd work, but I soon found out. My first patient, whom I'll call Ms. Amelia, was 39 years old. The electronic health record told me she needed to be seen for fever/body aches times 4 days. When I dialed her number, Ms. Amelia immediately picked up. "This is Dr. Nundy from the clinic," I said in Spanish. I almost reflectively followed with, "What brings you in today?" before settling on, "My nurse asked me to call you for a visit." If Ms. Amelia shared my hesitation with virtual care, she did not show it. She jumped into her story. She had body aches for the past 4 days and a fever the previous night. Her boyfriend had gotten sick 3 days before she had, and she was worried they could have COVID-19. Although I wished I could check her oxygen level and examine her, I couldn't and likely didn't need to. She had no shortness of breath or cough, and no chronic health problems to speak of. I ordered a COVID-19 test. 3 hours later, through my clinic window, I saw her minivan pull up to the clinic parking lot, our makeshift drive-through testing site. Soon, one of my nurses, in blue mask and face shield, walked over to her car to administer a nasal swab test. 2 days later, her COVID-19 test came back positive. Shortly thereafter, she fully recovered. Within weeks, what would have seemed impossible just months earlier had become routine. Our clinic, like many around the country, went from 0 to 70% virtual visits. We had trained all of our frontline care teams on new protocols and set up a drive-through testing site. But perhaps most important, we had upended ingrained workflows and thrown many of our deeply held assumptions about where and how healthcare needed to be delivered out the window. Although the shift to virtual care was a bright spot, it became clear as COVID-19 wore on that these innovations were falling short. How COVID-19 exposed design flaws in healthcare. Any hope of containing this pandemic would require a superbly functioning health system. But instead, we had a system that failed us in many respects. Some failures were related to the interference of politics, others to widespread mistrust of science, and still others to lack of public health capacity and pandemic preparedness, issues that are beyond the scope of this book. But chief among the many failures is how healthcare is fundamentally designed. Lack of access to medical care. Perhaps more than anything else, lack of access to testing became symbolic of our failed COVID-19 response. There wasn't enough testing capacity. There weren't enough laboratories to run COVID-19 test samples. There weren't enough test kits and test supplies. But lack of access to testing was also indicative of a deeper design flaw in our healthcare system. Lack of access to medical care. Far too many people today lack access to affordable healthcare. They are uninsured or underinsured, live in communities without enough doctors or that are mistrustful of them, or face financial or logistical hurdles to seeing one. They are disproportionately poor, come from racial and ethnic minority groups, and live in rural areas. In short, inadequate testing was just the symptom. Lack of access to care was the disease. Over-reliance on doctors. Early in the spring of 2020, as the first wave of the pandemic was hitting hard in my community, nearly every patient I saw was for COVID-19. Over video or telephone, I would ask them a series of questions. What symptoms do you have? Cough? Fever? When did it start? Any known exposures to COVID-19? Any difficulty breathing? Because COVID-19 was so prevalent and the symptoms so nonspecific, I would inevitably order a COVID-19 test for nearly every patient who called. It occurred to me that I was serving a function that could just as well be handled by a non-physician or an online self-assessment. It's not that I minded these calls. In fact, quite the opposite. It felt personally rewarding to help my community in a time of need. What concerned me was the inadvertent harm. Requiring every patient to be seen by a doctor created a bottleneck to testing and care. Only patients who had a doctor and could afford to be seen by a doctor received care. I was also concerned about the opportunity cost. Instead of managing the crush of routine COVID-19 patients who didn't need the expertise of a physician, I could have instead focused on helping higher-risk patients with COVID-19, or patients who needed care for their chronic diseases. Not for the first time in my career as a physician, I felt frustrated because I couldn't reach the patients who needed me most. Over-reliance on clinics. As more care became virtual, much of clinic-based care was exposed as unnecessary. The check-in usually performed at a front desk could be done over the phone. Time spent in a waiting room certainly had no value. Routine physical exams for healthy individuals, something we've known for years are usually unnecessary, were abandoned, even when visits were in person. During the pandemic, we learned that often the safest, most efficient place to get care for COVID-19 was outside of a clinic, through a combination of virtual visits and drive-through testing. But in most clinics, this innovation wasn't extended to other health conditions. By and large, patients with preventive and chronic care issues still had to come to a clinic to receive comprehensive medical services, and, as a result, many didn't. Over-reliance on hospitals. Early in the spring, when New York City became the epicenter of the U.S. epidemic, the world was horrified by scenes of overflowing hospitals, stories of families not able to be at their loved ones' bedsides, and cases of patients dying at home of treatable heart attacks and strokes for fear of catching COVID-19 in the emergency room. It became clear that hospitals and emergency rooms were, by design, maladapted to the challenge of COVID-19. Because hospitals are expensive to operate, they need to run at or near capacity, which makes it difficult for them to operate at surge capacity and accommodate more patients. Moreover, hospital care often requires doctors and nurses to go directly from one sick patient's room to another, increasing the risk that they will become infected themselves and spread infection to others. Hospitals, by their nature, bring thousands of people into the same physical location, which also makes them potential breeding grounds for infection. Yet, even though hospital-level care can be provided safely in people's homes, during the pandemic, hospitals seemed to be the only places where patients with more acute health issues were being treated. Lack of systems for chronic care and prevention. During COVID-19, preventive and chronic care declined precipitously.
Sample complete. Ready to continue?